Welcome back to Psychedelic Therapy Frontiers, the podcast devoted to exploring the frontiers of psychedelic medicine and what it takes to cultivate a healthy mind, body, and spirit. I'm Dr. Steve Thayer. Today, my co-host Dr. Joe Flanders interviews Dr. Anthony Back. Dr. Back is a co-founder of VitalTalk, a national nonprofit that provides innovative, interactive clinician and faculty development courses to improve communication skills on an individual and institutional level. Dr. Back is also a professor of medicine at the University of Washington in Seattle and the Fred Hutchinson Cancer Research Center. Dr. Back earned his MD at Harvard University, and he's triple board certified in hospice palliative care medicine, medical oncology, and general internal medicine. In his role as a medical communication educator and a VitalTalk co-founder, Dr. Back was the principal investigator for Oncotalk, co-wrote Mastering Communication with Seriously Ill Patients, released the first iPhone app for clinician communication skills, and authored the online communication skills curriculum offered by the Center to Advance Palliative Care. In 2019, Dr. Back wrote an article in the Journal of Palliative Medicine called What Psilocybin Taught Me About Dying. So in today's interview, you'll hear Joe talk to Anthony about the difference between improving quality of life versus having a good death, how Anthony's personal psilocybin experience changed the way he thought about death and dying, what it's like to grapple with the need to understand the great mystery of life and death, and of course, much, much more. If you're enjoying the show and you'd like to support us, you can do that by leaving a review or a rating in places like Apple Podcasts and Spotify. If you're listening on YouTube, you can like the video, subscribe to the Numinous channel, and share the episode with a friend. If you want to contact us, you can email us at ptfpodcast@numinous.com. Without further ado, here is Joe's interview with Dr. Anthony Back.
Okay, I am very pleased to have Dr. Anthony Back on the show today. Anthony, welcome to the show.
Thank you, Joe. Nice to be here.
How's the day so far?
My day is going well, actually.
What are you up to today?
Well, I was doing a little work on my study, working out paperwork and kinks and process. But but I think we're onto a new level of process complexity.
Gotcha. Yeah, sounds interesting. So I know you primarily as a palliative care doctor, and I'm really excited to chat with you about that and how psychedelics kind of intersect with that field. But let's start with some basics. Maybe you can tell me what you do and how you got into that line of work.
Sure. So I originally trained and practiced as a medical oncologist. I got into that because when I was a sophomore in college, my mother died of a blood-related cancer. And so at the time, I was like, holy cow, I have to figure out how to live. And that took me into medicine, but took me into medicine with a particular background. I had ended up studying humanities and writing a senior thesis about James Joyce and Virginia Woolf because I was interested in narrative and how people construct stories. And I went into medical school with kind of that background. In medical school, I had kind of a tough time because I didn't like sitting in all those lectures. And it wasn't until I got to actually talking to patients in the clinic that I felt like I was maybe in the right place. And after medical school, I did a medical oncology fellowship and was a practicing medical oncologist. I had a career development grant in basic science where I was making transgenic mice, like mice with an extra gene, because I was interested in the differentiation of white cells. And I was making all these genetically altered mice and breeding them and learning to breed them. And I had this moment where I was like, holy cow, I'm going to become a mouse breeding doctor. And I was like, I don't think that's the future. That's really for me. And at the same time, I had been dealing with all these issues at clinic where I was with these people who were dying or thought they were going to die or were worried about dying. And I really didn't have a good way to approach it. And I went to a famous medical school and followed all these famous people around. And they didn't know how to, obviously, they didn't know how to do it either. I mean, it was really kind of avoidance or diversion or minimization. And having been with my mother and lived through that with my family, I just thought, this is not quite right. And so that's what got me into palliative care. So I kind of made a career switch. I was part of the generation of physicians who developed palliative care in the United States. It lagged behind Canada in that respect, and we turned palliative care into a thing. And so that career was very rich, and I ended up doing a bunch of research about how doctors and patients communicate, especially about how do they talk about bad news, how do they talk about prognosis, how do they talk about what's going to happen in the future, and learned that there's a whole set of skills that I really didn't learn as a trainee that we turned into a startup with a social entrepreneur kind of background. And so I basically took lessons from the social entrepreneurs in Seattle and San Francisco and raised money and created a nonprofit startup called VitalTalk that scaled communication training in small groups with actors with a very specific kind of evidence-based learning model. And so I've spent years and years, sitting with people who are dealing with their cancer or dealing with a life-threatening illness, and also with doctors and other clinicians who are trying to figure out how to do that. And that's what kind of set the stage for me to get interested in psychedelics.
Very cool. Very cool. For those of us listeners who aren't that familiar with palliative care, maybe you can tell us exactly what it is and what is the role of a palliative care doctor, what makes a good palliative care doctor, etc.
Oh, sure. So palliative care is a medical specialty that involves a team of multi-professionals that is aimed at improving the quality of life for somebody who is living with a serious illness. So it deals with the stress, the symptoms, the coping, the future planning, all that kinds of stuff. And it's really for any age and any stage of a serious illness. I think of the big parts of serious illness care as there is advanced care planning, which is for everyone, talking about what kind of care is important to you now, what kind of care might you want in the future. There's palliative care when you are dealing with a serious illness. Then there is hospice for when you are really in the end of life care phase. And many palliative care doctors move amongst those things and do all three of them. But the reason I distinguish palliative care from end-of-life care a bit is because many patients decline palliative care because they think it's only for dying people. And, the fact is that that's not where the real benefit is, right? The real benefit is for people when they're still dealing with their illness, because we're enabling them to live better, take on the challenges, work with their families or the people who are around them. And that's what palliative care does.
Cool. I was sort of intrigued in looking into some of your work and just my curiosities about this field in general. Maybe, I don't know if there's a distinction, but in my mind, I'd love to hear you kind of speak to this potential distinction between improving quality of life and helping people have a good death.
Yeah.
How do you see those two things?
Well, I mean, I see them as really interlinked. And the reason I mentioned the reason I lead in thinking about palliative care as living well with a serious illness is because when we are talking to patients who are terrified, they mostly do not want to talk about having a good death. Right. There is this long, venerable tradition of hospice care in North America that came from the UK, Cicely Saunders, right? The idea that there was care for dying people, which was revolutionary at the time. And yet, what we have found is that when you're coming from the point of view of talking to the general public, about 10% of the general public wants to talk about having a good death. The other 90% of the public does not want to talk about having a good death. And if you say, oh, we have a service that's about having a good death, they're like, thank you, I don't think I'm ready for that. And in the United States, there was a survey of healthcare executives, large, cancer centers, other large hospitals. They reported that 60% of the people who could benefit from palliative care in their facilities don't get it.
Right.
And the largest reason is that they decline. So, the way I see it as kind of a developmental, evolutionary thing for somebody who is living with a serious illness. When you are first diagnosed and for a while into your disease-modifying treatment, you were really thinking about living well. You're thinking about, can I beat this? You're thinking about, can I extend my time? Can I do all this stuff? And at some point, in a healthy trajectory, people will make a shift to starting to feel that they can think about their death, that death might be okay, that they could even imagine it, that they could start to prepare their families for it. And so I think the issue that we face, and this as a psychologist, is when you confront people with something they don't really want to talk about, like, don't you want to talk about your upcoming death? They just react and push back. And actually what you get is more resistance,
Right.
more than introduction to the topic. So that's why I'm distinguishing those two. In a way, in practice, for an experienced clinician, they flow right into each other.
Yeah.
But from the point of view of the public, there's a very clear distinction. And I think one of the reasons that palliative care has not had more penetration in the United States is actually this issue.
Wow.
Yeah, it's really interesting. I've just finished this big public messaging project, and we have just reviewed all the data, all the empirical data about consumer perceptions, right? So these are people who are not yet patients, but they are people who get health care. And they are very, very clear. They do not want to talk about dying, and they think they have all these misconceptions about palliative care. Most of them don't even know what palliative care is. And so we have a pretty significant messaging issue around this. And I think it's relevant for our audience because I think it's going to be very relevant for the future of psychedelics in this space. That if we focus the future of psychedelics on helping you have a good death, I actually think we will miss out on a large number of people who actually would end up dealing with all their mortality issues during their trip, but would be a little reticent to say, ooh, that's why I'm going to do this. Right. So I'm very interested in this as the future of psychedelics for serious illness care, honestly.
Right. What an interesting kind of challenge or sort of issue to explore. I'm suddenly wondering why I'm in the 10% of people that actually want to talk about the good death. And if I'm going to lose 90% of our audience here, what do you think about that?
No, you know what? I think it is, you as a clinician, you've talked to a lot of people who've dealt with this. You've seen a lot of different ways this can go, right? You have a whole repertoire of possible stories about what happens when people are dealing with a life-threatening illness. The general public or someone who has just been diagnosed, they don't really have any stories. They have the stories that we have in the media, and the media stories are very odd. They're very skewed in a particular way. First you get the diagnosis and the person valiantly fighting with cancer and living normally. And I think of the actors in People magazine who get, cancer. Like, they look great and they're all doing their same thing, right? Then they disappear for 6 months or a year or somebody, and then they come back and they disappear and then they're dead. I mean, I think of Barbara Bush, the wife of the American president, who was out of the public spot. She got sick, she was out of the public spotlight, then she came back and said, I'm getting palliative care, and then the next day she died. Right? Aretha Franklin, right? Metastatic cancer, stopped her tour, said she would resume, comes back, says she's getting hospice, the next day she's dead. I mean, literally, that's the story over and over in the public sphere. So there is this very odd absence of real stories about what it's really like to live. And so we have, people who don't know this and don't live in the clinical world that we live in, they have one kind of story that's about everything's normal and everything's fine and I'm just like the way they am, that's not really quite realistic, right? And then there's like nothing, right? So I think that's part of the issue that we face in talking to people about ways to deal with what happens when you are in the thick of a life-threatening illness.
Mm-hmm. Well, okay. I got very intrigued by your statement that um, the best or most promising kind of context for psychedelics might be this quality of life piece more so than the good death piece, which was maybe my bias going in.
Yeah, yeah. Well, so I should say this is an empirical question.
Okay.
Like I don't think we know, there's not enough data yet about what it is. I
Yeah.
think that the existing studies of people with cancer, for example, who had psilocybin, at Hopkins and UCLA and, NYU, they're tiny studies. There
Right.
were like 30 people in each of them. So if you take all those studies put together, it's actually less than 100 people, and they were highly, highly selected patients, right?
Right.
Both of those sites recruited for over 3 years to get 30 patients because nobody knew what psychedelics were about.
Right.
Not all of them had incurable cancer. And so I think they're a very particular set of patients. And I think the question is what is this going to look like when you scale it up
Yeah.
and you take on all these other patients, many of whom will be in the middle of anti-cancer treatment. There weren't that many people who were in the middle of anti-cancer treatment during those studies. And so, so I think there's just a lot for us to learn. And I think it might be that initially talking about a good death and talking about how do you want to face your death might be a really great hook for a certain number of people. But I think there will be another group of people for whom, how do you want to make the best of whatever time you have left?
Yeah.
Right? Will be a whole different kind of hook, even if the base issue, the issue they get to during their trip is kind of the same issue.
Right. I can see that there is a possibility of like overdoing the distinction as well, because they sort of blend into each other, right? And, I wonder if I can dive into something that you wrote, this piece in the Journal of Palliative Care Medicine.
Sure.
Or Journal of Palliative Medicine, 2019, What Psilocybin Taught Me About Dying. And I'm seeing here that this is both about a good death and quality of life. But I wanted to kind of pick your brain a little bit. You said something like, you had this psilocybin experience. Your kind of like small manager self kind of disappeared for a while, but then kind of came back online. And then you said, but when it came back online, it was accompanied by an ineffable sense of the beyond. And that has altered the way you think about dying and how you talk about it with patients. I'd love to just hear more about what you mean by that.
Yeah. So I came into that was my first psychedelic experience. I had never even done any drugs in college, right? I'd never smoked pot before. I was a nerd. And I came into this thinking kind of as a materialist, when the body goes, consciousness goes, and that's over. And I have to say that my own experience with psychedelics has kind of shifted my worldview with this kind of, in a way I did not expect. And that first psilocybin journey really put me in contact with another sense of what is out there in the universe that kind of changed my, really strict materialist view on what this existence is all about. Of course, I don't think I'm not far from the only one to have reported this, but it really changed my sense of what happens when people die or when I die from this, what happens to my body and my personal identity and my ego and my individual self. As a doctor, I'm very trained, and the individual is the unit of treatment, right? To this sense that actually there is something more that we are mostly just not in contact with, but there is in fact something else out there. And the reason that that shifted my worldview is that understanding that we are connected to something out there, even if we're not aware of it in our normal everyday lives, that actually gives death a somewhat different meaning. There is both an individual version of this now for me, and a much larger version of where I fit in the big universe. And it sounds really airy fairy, but it's uh weird, honestly. It's yeah. So not having come from a very not a very particularly spiritual childhood,
Mm-hmm.
this has been a big shift for me.
Mm-hmm. So, what do you say to the listeners who, I mean, most of them are into psychedelics, so there are probably not that many of them, but the ones who are a little more attached to a materialist view of death and our
Yeah,
bodies, and, um, consciousness emerges from, you know, actual physical matter between our ears. And once that matter is no longer supported by a living body, the
yeah,
lights go out and that's it. Like,
yeah. Well, so you know what I would say, and this is what I would say to a person who's considering psychedelic therapy, or somebody who's considering this. I would say, uh, you, we do not have to have an argument about this now. I would say you can just go into this experience
yeah.
with a question and see. And you don't even have to have a question of, is there something more? You can have a question of, what am I going to do with this life? What's going to happen to this body? What's going to happen to the people I care about after I leave, if that's what I'm worried about? I think it's plenty to go into an experience with those kinds of questions
Mhm.
and to see what kinds of answers are given. Um, does that make sense? Like, I don't think you have to convince people to have the spiritual outlook before they go into it. And in some sense, this comes from my bias as an educator, that
Right.
the experience is primary. Like, you
Mhm.
should make sure people have as rich an experience as possible, and then debrief it like mad,
Mhm.
right? And what that means is that you pay attention to what the people's safety, you pay attention to your relationship with them, you pay attention to building a level of trust where they will accept little nudges and suggestions from you as the therapist, and see where all that goes.
I'm also curious though about, someone who's sort of intellectually curious about what you're saying.
Yeah,
So you're accompanied by an ineffable sense of the beyond. And
yeah.
of course, by definition, it's mysterious. But how would, given that you're a doctor and you live in the physical world, how would, and communication is important, right? You want to make this digestible for somebody listening. Purely on a sort of metaphysical basis, what is this beyond business that you're talking about?
It is the great mystery, right?
Okay.
I
Yeah.
mean, I think if you take it, I think the ways that humans can have conceptualized this are
Yeah.
part of the wisdom traditions and the great
Yeah.
religions, right? So I think
Yeah.
there are Christians who would say this is God,
Uh-huh.
right? There are Buddhists who'd say this is the Dharma,
Mhm.
right? The Jungians would say this is the collective unconsciousness,
Mhm.
and all that lies below that. So I do think humans have struggled for millennia to try and wrap their heads around this,
Yeah.
right? And try and put language on something that
Yeah.
is really, you know, impossible to describe. And
Sure.
and I think that is something that actually, as physicians and clinicians, we actually should be open to, because I think
Yes.
our materialism actually really affects how people see their own
Yes.
life and death. And so I think one of the ways that we have to be careful here is to figure out how we can meet the language and the way that patient talks about this or approaches this. Because, you know, in our very secular world, the ways that patients talk about this aspect of their experience is sometimes quite hard to discern. And I think many patients, especially patients, you know, as an oncologist, patients coming to a cancer center, they're embarrassed that they don't think that it's something that I want to talk about with them, right? They actually downplay their own beliefs and own experience because they think when they come to these big medical centers, they have to play by
Right.
the medical rules. And the medical rules are, you know, materialist and procedural and consequential, right?
Yeah. Yeah. You know, I'm with you on, you know, well, first of all, the choice of word ineffable, and actually the futility sometimes of really trying to nail sort of modeling this thing with language, that there's actually something quite empowering about being able to just be with the mystery. Um, and you know, it does strike me as like this desire to uh, kind of put language on things and like figure things out is the domain of small self to take your language.
Totally.
And that you talk about like the importance of allowing that to dissolve. And then this beautiful phrase that you have here about developing some ability to tolerate or some comfort with having the sense of the small self dissolving. It offered you something alive and potent, right? So that there's something, I don't know what, healing or liberating or empowering about being able to be with the mystery. So what did you mean about alive and potent, and how did you get there?
Yeah. Uh, so, uh, what, you know, I think in my own experience, my psilocybin uh, trips have put me in contact with what feels like this larger energy in the universe, like this sense that I have that I am uh, channeling the kind of creative intelligence of the universe, whatever that might be, you know, and that might be the Dharma. And for some days, for me, it might be something bigger in some days, other days. Um, and although it's not something I necessarily would talk about with a patient, I mean, it does give me a bigger sense of what I am doing in even a clinical encounter.
Mhm.
And I think it also helps free me up from the sense that my actions are the only things that are going to happen. There's much more happening in all of these clinical interactions than I can control or even understand or be aware of. And I think that brings me into these encounters in a different way. It's a bit more of a humble way. There's a bit more of what Harvey Chochinov would call the clinical humility of it all. And it also puts me in a frame of curiosity and discovery, which is very different than what I was trained. I was trained as a medical oncologist to be very predictive and be very
Mhm.
prognostic and to know what the survival curve looks like and to know what the median survivals were and to educate people about that. And you know, that has definitely some benefits. You know, this is what you should be, you know, this is what I'd want you to be prepared for, kind of thing. But it also feels to many patients very deterministic and limited and not very imaginative. And I do think that is one of the reasons that people who are living with a life-threatening illness resist much of the language of prognosis that
Mhm.
that
Mhm.
specialists try to give to them.
Mhm.
um, and it is actually what as I see it. You know, now I've listened to thousands and thousands of recorded conversations between doctors and patients, and I think it is one of the sources of tension that often arises in these conversations.
So I'm not sure if you followed the story at all, but I just became aware of Roland Griffiths' kind of announcement. He's got
Yeah.
stage 4 cancer, seems to be terminal, and he's been quite vocal about his experience. And what
Yes.
he has to say is really quite beautiful and inspiring. Um, you know, in particular, what really stuck with me is the sense that he uh, is kind of reacquainted and deeply committed to this sense of gratitude for just being alive and being in contact with the great mystery of that, and the
Yes.
privilege of, you know, just this miraculous thing that we get to do for a few years,
Yes.
and there's so much generosity, so much warmth, compassion, and how he speaks about it. And of course, this is he's on podcasts and whatnot. You It appears that this is authentic, and that he really is sort of coping with this and leaning into the experience he's having with this kind of spiritual integrity and meaning and this kind of stuff. I wonder what you're sort of picking up there, because it really does seem like he's someone who is, really maxed out on his quality of life and is setting himself up for a really good death.
Yeah. Well, I think Roland is right now, he is being an amazing teacher,
Right.
right? Like this is an amazing teaching for all of
Mhm.
us. And I think, my own, as I have listened to him, I have heard both this issue of his experience with psychedelics to put him in touch with this ineffable thing that you and I have been talking about a bit, and also his long-standing meditation practice.
Yes.
Right. It turns out I'm a long-time Zen person too, and I
Mhm.
do think there's something very potent about that combination in enabling you to um, live in the present moment. I mean, it sounds like a cliche these days, like everybody is talking about living in the present moment. But when
Mhm.
you are under the gun of a serious illness, there's a whole different quality that takes on.
Yeah.
And it is interesting to me. I listened to him the other day on Sam Harris's podcast, and it was interesting to me that as his situation has become more medically serious,
Yeah.
it sounds like his sense of the richness of the present moment has actually increased, right?
Yeah.
And if you talk to, you know, the people I really consider Zen masters, for example, that's the tradition I know the best. I definitely have heard that kind of thing before, and I think what he is living now is the life of a practitioner who has been deeply committed to practices that train the mind to pay attention to what's really important, right? And so that's what he's doing. So he's not being distracted by a whole myriad of things,
Yep.
right? He is actually right here. And what that has led to is this um, deep sense of gratitude. And I have seen that in people in people I've worked with too, this deep sense
Mhm.
of gratitude. And
Mhm.
I've seen it come out of people who have finished a psychedelic experience.
Right.
It is a deep sense of gratitude. I think the complicated thing about that is that, he's been practicing for
Yeah.
decades,
Yeah.
right? Like this is not like
Yeah.
somebody who just like turned on Headspace a week ago, right? This is I mean the structure of his brain is probably different than the structure of my brain, and
Uh-huh.
he has cultivated that over time. That's why there are these, in Tibetan monks who spend all their time getting ready to prepare for death, because it actually takes a
Yeah.
lot for all of us to do that. And I think he's showing us. And I think it's a fascinating, incredibly generous public teaching, especially for someone who's been, until this point, very reticent to talk about his
Right.
own psychedelic experiences. So this has
Right.
been a real sea change. And I think he's doing it very deliberately as a teacher.
Mhm.
So I
Yeah.
am full of admiration for this.
Yeah. Something incredible about hearing him describe gratitude for the cancer,
Yeah.
for like um, helping him move to, I don't know, for lack of a better phrase, just like a more like more feeling more woken up, more sort of
Yes.
enlightened in a way.
Yes.
And it really does seem like a high bar, right? Like, wow, am I going to be able to do that?
Yeah. I mean, I will say that I've heard that a version of that from lots of people with cancer.
Uh huh.
Like, actually, there has been a silver lining to this for me.
Right.
I have realized this. I have reconnected with this. It has made me spend my time doing this. It has let me shed a bunch of this other stuff. And
Hmm.
so I think what I'm hearing there is an extreme version of something, a very advanced version of something I hear from lots of people in terms of this.
Right.
But because he has, he's able to sweep the deck of
Mm.
his other distractions and things and really dive deeply into the experience of this moment, he has this really deep, this immense sense of gratitude that comes through when he talks. And, when you listen to him, you think, wow, that seems kind of unattainable, right? Like it's, as you said, a high bar. It sounds, it is really up there. But I mean, in the way I think we should look at this, like you look at the experience of other like spiritual teachers who are telling
Yeah.
us what's
Yeah.
possible in
Yeah.
some places.
I'm going to share something personal that, can regularly make me emotional. So just, fair warning here. My mom said something. She died a few years ago. She had dysplastic anemia,
Oh,
and she had really good quality of life for about 4 years, and then the last 6 months were less so. But again, I think I mentioned to you before we started that she had a really amazing experience with the palliative care unit at the Royal Victoria Hospital, McGill here in Montreal. But it was maybe halfway through this 4.5 year period. And my family was one where there was a fair amount of conflict and not everybody got along and it was a bit complicated. Probably one of the reasons why I became a mental health person. But, we were all aware of the seriousness of her situation and would, get together and all be really on our best behavior so we could enjoy the quality time knowing that there wasn't that much left. And at one point, we were actually enjoying like quite a lovely time together, which was rare. And she pulled me aside and she said, if this is what it took for us to really come together, it's worth it. I was like,
wow.
how does that math add up?
Yeah, yeah.
But and like this
Mhm.
was not
Oof,
kind of
it's
like a
really beautiful.
throw. Yeah, right.
It's beautiful. Oh my God.
It was not a throwaway like Hallmark card kind of statement. It was my mom like really valuing the people she loved and really, wishing for everyone to be together and connect and enjoy each other.
Yeah, yeah, yeah.
Um, and so she, again, this I guess was an expression of gratitude for her illness. And she was not a meditator, believe me.
Yeah, yeah. And what a beautiful story. And it just uh, reminds me how people in those situations, all of a sudden they could take the big picture, right?
Mhm.
Like this is about a good that is greater than just her. It is about a good that was about your family that she
Right.
cared deeply about, and clearly could see something going on there, right?
Yeah.
It's really beautiful.
Thank you. I continue to think so as well. So I hear you that meditation can be a powerful tool for cultivating these kinds of attitudes for that period of one's life. What else are you seeing um, that could really help people have good quality of life if they're seriously ill and have a good death? And of course, maybe I'd love to hear all of your ideas, but I guess the question of the day is where do psychedelics fit into all that?
Oh, yeah. Well, so let me give you the big picture first, and then I'll hone down on the psychedelics.
Yeah.
When people are dealing with a life-threatening illness, they need to feel like they have good medical care, doctors they trust, treatments that match up what they are hearing about in the news, right? Uh, Places for that treatment to be given compassionately, right? That's super important. They have to have their symptoms controlled, right? They have to have their psychological needs met in some way. And I think then when you get down to the spiritual thing, which is actually, I think, a very deep seated need that the medical system doesn't
Hmm.
really have a great way of treating. I don't mean to undercut the work of chaplains and spiritual professionals who work in medical care. I think they do an amazing job, and yet they often are trailing behind the whole complicated routine of what happens in big hospitals, right? Like they're trying to sneak in whenever they can between the CT scans and the chemotherapy and the surgery, right? All the radiation. I think where psychedelics might fit in is when that stuff isn't forefront, right? Then when people are confronted or have the headspace to start to address, what we might consider the spiritual issues or the existential issues. What's going to happen to me? What is happening to me? What's going to be the consequences of all this for my family? What is all the stuff that I've left, that I'm going to leave undone? What is all the stuff that I haven't reconciled? I think that's where psychedelics could have a really critical role, right? I'm sure you've seen people who get into a really serious spot with their serious illness, and they're uncomfortable, they're unhappy, they're struggling, right? And many times I think we medicalize those problems and trying to figure out, what's the pain issue, what's the whatever issue, and it turns out it's something much deeper. It turns out it's really something existential. It's really something that's spiritual. And I think we have not had really great tools for that, that have allowed people to step out of the defenses that they construct for themselves to live in this world and to live with a serious illness, right? I mean, we all construct all these psychological defenses to live in the world in whatever circumstances we are given. And actually, I think in many cases, the competent, well-intentioned medical care that we give people actually requires that people amplify those psychological defenses. Like, think about what it takes to, get diagnosed with cancer and go to a clinic all the time and get chemotherapy and be on your best behavior and, try to be pleasant to the nurses who are coming in, giving you the stuff that makes you feel awful. And, not knowing for months whether it really is working or not, right? In this setting that feels to many patients now kind of industrial. It feels like they're in a big machine, right? And they say to me, I feel like I'm just a cog in a big machine. And I think all, bolstering yourself to like get through all that, I think can actually distract from the other real issues that you're facing. The issue that your mother mentioned, which for her probably, I'm just going to speculate a bit, is what's happening to my family here and what's going to happen to them after I leave. Are they just going to, is everybody going to split apart? Is everybody going to come together? Right. I mean, for her as a mother, that I'm wondering might have turned out to be one of the central things for her. Right. And how do you get to that? Because the process of medical treatment is pretty distracting and it's pretty all consuming. I feel like there's a way in which we've turned people into like professional patients who know how to deal with the system, who know how to get the tests, who know how to manage themselves. And what it does is it doesn't leave them any space to start to feel into this other stuff.
Right. And I'm sure for many people, I can imagine myself in the situation, having all that to do, all the appointments, all the analysis, all the reflection on these practical things is a welcome distraction.
Totally. I mean, you know what? We live in a distraction society, right?
Yeah.
Our attention is a commodity. And if you look at what happens on Facebook now for people with an illness, and this has been happening ever since the listserv days, it's people bombarding you with things that you should do. Like you're the one with the illness and you're getting bombarded with, you should do this, try this, talk to this person, blah, 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 blah. And it can be a little overwhelming for people. And so that, I know patient advocates who now recommend to newly diagnosed people that actually they try to stay off the internet and try and limit their contact because they feel like they're being, and put in front of a fire hose. And
Yeah.
it is a symptom of our culture at large, right?
Yeah. Yeah.
We live in a distraction society.
So, yeah, maybe I can, a couple questions here. So the first one, what can you tell us about whatever kind of research there is on psychedelics in this field? I know not a huge it's not a huge literature just yet. We know Roland, who we were just talking about, contributed to it. What's the kind of state of the science at this point?
Yeah, yeah. Well, so I would say the state of the science is that we have a small number of studies that show very promising results for distress, symptoms of depression, anxiety, and this existential kind of what's being called existential distress
Mm-hmm.
related to a life-threatening illness. I think the mechanisms of how psychedelics work, I think the subgroups of patients for whom it would work the best in, the time in a life-threatening illness it would work the best, are all still up for grabs in terms of understanding where the research is. I think the
Yeah.
other issue is, could there be group interventions
Right.
that are done as an alternative to individual interventions for, screened, carefully screened patients, that could those be as good or maybe more powerful? There's this big literature in other cancer group psychosocial interventions that shows that there is a clear benefit in randomized trials for group interventions without psychedelics, where people talk about coping, they share their experiences, they support each other. There's even some data that indicates that those people who participate in those interventions live longer. So there's clearly something going on there. And I think there's a lot of room in the field to flesh this out and help
Mm-hmm.
us figure out how to put it into practice.
Mm-hmm.
I think of the existing studies now as kind of proof of concept studies.
Right.
They are really powerful. They're really intriguing. There's clearly something there, I would say. And I think the question now is, how do we flesh that out?
Yeah. So, can I ask you to take a stab at fleshing it out? What does it look like? Imagine we're 10 years from now and there's some, legal regulated pathway for your patients to have access to psilocybin.
Yeah.
And you basically have carte blanche here to
Yeah.
paint the picture of what it
To do
looks
the
like.
thing. Yeah. So then so if I were the oncologist 10 years from now, I would say, wow, there's a lot of stuff going on for you aside from this medical stuff. Why don't you have a consult with my psychedelic therapist colleague and my psychedelic therapist colleague? We'll talk to you about what the options are and see if there's something that fits right for you and talk to you about what that might be. And so then, they'd come to see a psychedelic therapist. And if they had a lot of PTSD from their treatment,
Yeah.
it might be that the psychedelic therapist would point them towards MDMA.
Mm-hmm.
If they had really predominantly existential stuff, maybe they get pointed more towards psilocybin. And, I think this would all be done in the context of a kind of a preparation that is different than the existing research preparation. I think the research preparation right now makes perfect sense. It's a defined number of
Yeah.
visits. It's a protocolized and in a good way, because I think that makes it repeatable. But when I've spoken to psychedelic therapists in Switzerland, for example, who have used LSD on a compassionate use basis, they think of the preparation as very variable, and they have some things in mind about when people are ready. And I think in the future, we will have a better idea of when people are really ready, when will people benefit the most, how much preparation do they really need, and what might we be able to look at as signs that someone has gotten to the point where they're really ready. And so I think we'd be saying to people, let's enter into this and see how the preparation goes and see if we think a psychedelic thing is going to be the right thing for you. So I wouldn't be a promise that you're going to definitely get it in 2 more sessions. It might be more of entering a process of discernment about, let's enter into this and see if there might be something here that really is suited for you.
What about after?
Yeah, and then afterwards, I think there's this thing about follow-up therapy that, again, certainly pays attention to what we are learning from integration studies now, but also being open to the possibility that there is much longer work that needs to go on afterwards. I'm doing this study now, psilocybin, for doctors and nurses with symptoms of depression and burnout from their work in the pandemic. And this study is set up as kind of a classic 2 therapists, 1 participant study. There are 2 sessions before, 3 sessions afterwards, and it just feels really short. And there's a lot that we finished these 3 sessions, which are done in 3 weeks after the trip, and there's still a lot going on for people.
Right.
And so I think in the future you as a psychedelic therapist would have a lot more flexibility into, what do I think is the best thing here? What do I think is really needed? When are people ready to work on something and keep going? When are people really done and they're done?
It's an interesting one. Yeah. Sorry. Did you have?
No, that's my. So that's my little vision of the future here.
Yeah.
If I had my own way. Oh, and then there would be a group option.
Groups. Yes.
Yeah.
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 It's an interesting one, this integration piece, because first of all, I'm definitely a believer in, that it's not a protocol that decides when a person's ready to get opened up like that. And I'm actually really sensitive to, what it's going to look like after they get opened up like that. And, in the context here, in a private mental health clinic, can people afford to pay, often out of pocket, often,
right.
Here in Canada anyway, covered to some extent by, their health insurance. But, there's a risk in opening somebody up like that. And then when we're talking about someone with a terminal illness, there's a kind of hard stop at some point. And so I feel like that must enter into the calculation as well. Any thoughts on that?
Yeah, I totally agree with that. I mean, it's like sending people to big meditation retreats. People get opened up and then, whoa, all kinds of things can happen afterwards. And they can be. So I do think this is going to be another one of the things that we are going to learn about. What's the timing for these things? I mean, I have to say this issue of what is required for people to make sense of their trip and really benefit from it. That is what makes me a little worried about doing psychedelic therapy right at the end of life for people.
Right, exactly.
There are 2 issues for me. One is that I think it takes a certain amount of energy to do the psychological work. It's hard, right? And so if you're not physically going to be able to do that, if you don't have the energy, I guess I'm not as sure that just going on a trip is going to create longer term benefits. And the other thing is, I feel like doing things a little bit more upstream would actually give people the space and time to do that integration and enjoy the time, right? Like enjoy the benefit of doing all that work, right? So I think that's where we just have a lot to learn. It's not that I want to deny people, at the end of life, who are really at the end of life, the opportunity for this, but I am thinking about what's the place where we would, get the biggest bang for the buck in terms of a complicated, expensive therapy. The other thing I want to say here is that I do think this is where we as people in the medical world need to think about how could we interface in a future with more community-led things? Could there be community spaces where people go after psychedelic experience and continue to be supported, continue to share experiences, continue to have places to think and feel that are outside, everyday life? And not all of those would necessarily need to be led by a medical professional. And in some ways, I could imagine a future integration circles led by cancer survivors, people living with cancer, that could be incredibly powerful, and all the more powerful because they're not so medicalized. Right. And so I do think in psychedelic culture, I'm hoping that there will be space for both things. right? There will be space for the medically supervised stuff, for people who have complicated medical issues, right? Like you want somebody with some medical training to like screen you if you're a person with metastatic cancer who's in the middle of your therapy for a psychedelic treatment, right? That seems like sensible to me. And could there be community spaces that are constructed in safe ways for people who don't need quite that level of medical oversight, that might enable this whole thing about well-being to stretch into a different part of their lives and a different part of the community life.
Yeah. I'm curious to hear more about the study that you're doing with the healthcare professionals. Can
Oh
you say
yeah,
more?
yeah. So this is a randomized trial of doctors, nurses, and uh, nurse practitioners, physician assistants, provider level clinicians who have symptoms of depression as the entry criteria. So this, I think what doctors and nurses have experienced as a result of the pandemic is it's not for people who did not have a prior mental health condition, which are the people in this study. It's not ex- quite classic MDD. It's not quite classic burnout. It's not quite PTSD. It's something kind of that has elements of all things, is what I am seeing. I see clinicians who are um, deeply demoralized and deeply disillusioned by what they have had to do in the pandemic. They're people who are haunted by the dying that they saw, and they were very uncomfortable deaths in the early phase of the pandemic. I mean, people really physically suffered. And these clinicians are haunted by not having had the time or the equipment to take care of them in the way they usually had. Then the second wave in the US was this wave of, the vaccines came and they thought, oh, everything will be solved. And in fact, there was a whole new problem. There are people screaming at them, people spitting at them, people throwing bedpans at them, people accusing them of lying. And, these are clinicians who were like, holy cow, I did not sign up for this. And they, I think, found that deeply discouraging. And then there are people who I think have just had this enduring moral distress that has turned into something else. The sense that, what I'm doing isn't really helping anybody. It's not really doing any good. Why should I keep doing this? I'm just, a cog in this big machine. And so anyway, so that all that I developed this study that is a single psilocybin treatment, with the preparation integration for these doctors and nurses. We have enrolled we've actually treated about 2/3 of the patients in the sample. So we're kind of coming into the home stretch here. It's been a really interesting, beautiful experience to sit with these doctors and nurses. And I do think that for the people who end up in the study, who are people who did not have prior mental health issues, who had pretty significant symptoms. So we're using the MADRS as the eligibility criteria, and you had to have a MADRS score of 20. So, moderate symptoms of depression. So these are people who are pretty affected, right, symptomatically. But what's interesting about them, and I think what is a little different from the MDD thing, is that they are all still working. They all basically sacrifice their personal life so that they can maintain their productivity at work. They're all really identified with what it means to be a good doctor and nurse. They all work really hard. They have all massively tried to do all the other coping strategies. They all exercise. They all meditate. They've all done something else. They've been to energy healers. They've been to therapists. They've been to everything. They are very aware that they are having a tough time coping, and they are trying everything. So it's kind of an interesting group, and there have been some really remarkable anecdotes that I have seen so far. Of course, we haven't analyzed the data, and we're not there yet, but it's pretty easy to see who's gotten the medicine and who's gotten the placebo.
Right.
In this study, actually, if you are randomized to the placebo after the day 28 time point, which is the primary outcome, you can sign up for an open label session. And so we've done now a bunch of open label sessions
Hmm.
because we've not wanted to wait until the very end of the study to do the open label sessions because we thought it's just too long.
Mm-hmm.
And so those have been super interesting too. So, yeah.
So maybe broadening out from there, why psilocybin? Why not like,
Yeah,
um,
yeah.
in your study and maybe more broadly in the field, why not ketamine? Why
Yeah.
not MDMA? Why not LSD? Why not 5-MeO DMT? Like what's
Yeah,
the
yeah,
what's the
yeah.
deal?
Yeah, well, there's a certain pragmatism to it from
Yeah.
my point of view, right? Like psilocybin, I had access to through the USONA Institute. That was they were interested and very cooperative and very helpful. I actually had this hypothesis that underlying all these symptoms was a great deal of grief, right?
Mm,
And grief and this kind of aversion of this kind of existential thing from being surrounded by so much death.
right.
And there has definitely been a certain chunk of that. And then I think there's been some other stuff that we are still, characterizing. But that was why psilocybin.
Mhm.
I think you could do a study. I think there is somebody doing a study with MDMA. The reason I actually wanted to work with psilocybin and a classical psychedelic because I actually have the sense that they are more potent. I have less experience with ketamine personally, clinically, but that was my interest that was my investigator interest, and so that was
Yeah.
why I chose psilocybin.
Okay.
Yeah,
Um, staying with doctors here for a second.
yeah,
Um, I really um, have so much appreciation for the palliative care doctor that supported my mother, and just was blown away by how, like how open her heart was and how sort of emotionally available she was, how present she was. I think my mom fell into the category of people that like didn't want to talk about death, didn't just like leave me alone with that stuff. Um, and
at the
sure
beginning.
enough, pretty like it
Yeah,
took a while. She
it took
got
a
there, but it
while.
took a while. Yeah.
Yeah.
Um, and I guess it won't surprise you to hear that this Dr. Lawler was a meditator, and she was
Oh
part
yeah.
of the overlapping kind of mindfulness community that I'm a part of. And yeah, another one of those cases where she had a lot of practice. So I'm kind of curious now, just from the point of view of like practitioner training, right? How do you help a physician who, in medical school and residency probably has a lot to learn on a more sort of like practical basis, more data and models and protocols and things like this, more so than the bedside manner, how to connect with people. So how does someone become, or develop this capacity for presence and compassion that
Yeah.
I was so impressed by?
Yeah, yeah. Well, I know Dr. Lawler. She's a
Oh,
pretty remarkable person,
cool.
and has a deep meditation practice and a deep
Right.
background in this. And you know what I think we need to do as a field, which I think we haven't done, and maybe I'm wondering if psychedelics could help with this, is to make it clear that this kind of practice exists and it's real and it's more than bedside manner. Like, and I
Mhm.
don't mean to discount what you were saying, but I often hear bedside manner as kind of the surface niceties that people bring when
Mhm.
they're with a patient. Really,
Mhm.
when I think about what somebody like Dr. Lawler, she is doing something much deeper,
Right.
right? She is bringing her whole self into this encounter in a way over and over and over again that invites somebody, even somebody who's a little skeptical, to say, ooh, I really can let down my guard here. Ooh, I really do want to connect with this person at this level
Mhm.
because that is what's being offered to me here. It's not like the person, like when I was getting a colonoscopy, the woman was staring at the screen and says, are you safe at home? Well, right, like that was a screen on a questionnaire, but that is not what she is doing, right? She is
Right.
clearly doing something different. And I think what uh, there needs to be a sense of what is possible when you practice like this, a clear path of training to get towards that level of competence. And then I think there has to be an affordance in the system that says, actually, we want to support people like this. There is a
Hmm.
place for people like this in our health system. Right now, much of that kind of psychosocial work has been offloaded
Yeah.
to, the people who are the lowest on the totem pole, because the perception is that anybody can just do that. And in fact,
Right.
of course, having been with your mother and this doctor, the exact opposite is true.
Right.
It's not anybody who can just do that. And so I think this is, in a way, the heart of a kind of um, clinical encounter that is possible, that
Hmm.
psychedelics might make more visible. And I
Hmm.
think we need to use this opportunity, psychedelics, to say, what is it going to be that we want to see as this medicine comes into the clinic? Because I can tell, my clear belief is it's not going to be just about giving people the medicine, right? It's going to be about the people who are with the people
Yeah.
before and during and after when they get the medicine. That's really what it's about. That's really what is going to that's really what results in these outcomes. And I think it's important for us, as we think about how do we construct studies and look at
Yes.
outcomes and describe what the conditions are for this, that all that becomes part of the picture, so that it doesn't result in a thing where people are, you know, getting a psychedelic and being in a room alone and then doing some kind of follow up on their phone,
Yeah.
right?
Yeah.
Like,
Yeah. Yeah.
that's I just deeply don't think that's going to work. And
Right.
yet there are cost pressures that are going to drive
Yes.
that in that direction, unless we, as the leaders in the field, clearly lay out the case with data that, for it to really work, this is what's needed,
Hmm.
right?
So that's a really, maybe we can now wind it down after this follow up, because I know I'm conscious of your time and probably got a lot of work to do this afternoon. But I'm totally with you on the need to do this stuff with integrity, or else it's not going to work, as you say. And the cost pressures do reflect a challenge, which is, doing psychedelic work effectively does require a lot of input. And it's the therapists and the sitters and the guides, and um, there are not that many people that actually know how to do this work relative to the number of people that actually need that kind of support. Part of it is just like a scale question of like, how do we train people to do it? But how do and you did mention the group option, but how do you see the big challenge of scaling this very human scale work?
Yeah.
You going to leave that to the entrepreneurs, or do you have some vision for it?
No, I think actually is going to be up to us as, the people who are forming this field
Hmm.
to, we can actually learn some things from the entrepreneurs about scaling, but I would especially say that there are things to learn from the social entrepreneurs about how do you scale communities? How do you
Right.
scale communities of practitioners? How do you scale communities of lay people who can help hold these containers? I do think this is going to challenge us to look outside the existing medical models
Hmm.
for what is really going to make this happen.
Hmm.
And so I'm really looking forward to those discussions and those experiments, because I think they will be important ways for us to look at mental health as not things that only are located just in clinics.
Right.
Right. And
Right.
so I don't know that I have a preformed idea about this, but I definitely, in my experience, doing communities and doing group work, I've been learning to do group facilitation in the Netherlands at a legal
Hmm.
psilocybin retreat center. And
Hmm.
clearly there is a whole um, expertise in doing these groups that is definitely teachable,
Hmm.
scalable, right? All that stuff. And so, the fact that it seems far from reach right now, that actually doesn't bother me. I actually think we actually need to figure out what really works and how can we capture the best of what really makes it work,
Mm-hmm.
and figure out what the right size model is. So
Mm-hmm.
I don't have a simple answer for you, and I think it's a challenge that we really need to step up to, and
Mm-hmm.
especially those of us, I think, who work in medical settings
Yeah.
need to think about how do we partner with people in what are currently, different settings, so that we can really figure out a way to do this.
Mm-hmm. Yeah, I really appreciate that vision. That makes it feel a little more accessible. And I also hear you that it is incumbent upon the people that are in the field right now to communicate clearly about what's actually needed to take care of people properly, because the alternative is way worse,
The
right?
alternative is a race to the bottom,
Yeah.
right? I'm not kidding. I
Yeah.
mean, probably in the United States more than in Canada, but the alternative is a race to the bottom. And so if we're not super careful right now, you're going to be getting your package of psilocybin in the mail with a few little instructions and a video to watch, and they're going to go, "That's good," and I'm going to go, "Ooh,"
Yeah.
right?
Yeah. All right, Tony, thank you so much for
Okay,
doing this. This is so much fun.
Joe, so great to meet you. Thank you.
And I'd love to check in with you again when we're a little bit further into this field and see how we're doing relative to some of the things you have recommended for the field.
Yeah, totally. I would love to come back. Thank you.
All right. So wish you a great rest of the day. Anything else that you think we should cover before we break?
No, I think we've covered a lot.
Great. Anything you want to just mention in terms of projects you're doing, studies, any commercial activity? This is your opportunity.
Oh, I have a couple things in the works, but they're not ready to get announced yet. So, yeah,
Okay.
stay tuned.
All right. Thanks again. Take care.
Psychedelic Therapy Frontiers is brought to you by Numinous, a mental wellness company committed to tackling the global mental health crisis by delivering best-in-class psychedelic-assisted therapies, contributing to the body of primary and clinical psychedelic research, and fostering healing through community connection and social responsibility. You can learn more about Numinous at numinous.com. That's Numinus.com. If you enjoyed the show today and you want to support us, here's how you do it. Rate and review the show on platforms like Apple Podcasts and Spotify. Subscribe to the Numinous YouTube channel, like the videos, and share it. Share the show or clips of the show with someone that you think will enjoy it. The content of this podcast does not constitute medical advice or mental health treatment. Consult with a medical or mental health professional if you believe you are in need of mental health treatment.